Greetings, everyone. Welcome to the 218th session of the online Optom Learning Series, OOLS. And for today's session, we have with us Dr. Brianne Rhue. Dr. Rhue is a fellow of the American Academy of Optometry and also a fellow of the Scleral Lens Education Society. She earned her undergraduate degree from the University of Arizona before earning her Doctor of Optometry from the Nova Southeastern University. She has also done her residency in terms of at the Bessemer Palmer Eye Institute in Miami, and currently she's the owner of the West Profile Eye Care in South Florida. Dr. Rhue is a very passionate educator about healthcare and technology, does a lot of myopia management, specialty contact lenses, and also practice management. Today, Dr. Rhue is also going to talk to us about scleral profilometry. How can this help us in terms of our practice, and what can we take away from having a scleral profilometry? So welcome, Dr. Rhue, onto our platform. And I'm just going to ask you a question before we start. I wanted to know about doctor contact lenses as well. So I think you will be the best person to explain. So I just skipped that. And I would like to hear about what's doctor contact lenses all about. And welcome to our platform. Thank you so much. And let me leave the screen time to you.
Amazing. Thank you for the opportunity to be here and share one of my passions here. Doctor Contact Lens came out of a need out of my own practice in really doing all of the work and seeing all the patients. But in the US, we don't make it easy for our patients to order contact lenses from us. And so that's what we connected, was we wanted to make it easy and digitize the solution where patients could order their contact lenses from us and really create a CRM or customer relationship management tool where we could either see where they had never ordered from us, where they were due to order from us, or due to come back and see us. Because we know at the end of the day, a contact lens prescription should remain a prescription and remain with that doctor. And when our patients are able to invest in us, we're able to invest in them and keep our clinics and our passions healthy at the end of the day, because we're there to take care of patients. So that's what Dr. Contact Lens is in a nutshell. Always happy to share more. I've got my LinkedIn right there, so please connect with me there. You can always send me a message there, and we happy to connect as we can. Fakhrad and I were just talking about how small really this community is and how passionate we all are about taking care of our patients' vision. So I'm going to hop right in here to the presentation. So my financial disclosures right there. I'm, again, the co-founder of Dr. Contact Lens, Techify. I do a lot of myopia management and scleral lenses in my practice. And I recently bought the practice from a partner of mine where we had a 7-year buy-in, buy-out. And I was able to bring a lot to this clinic. So just kind of that one step in front of the other. And it's amazing how all of those steps really do add up over time. So I'll take you back here to my residency days. And again, thank you for joining me on your Sunday or Sunday evening, afternoon, wherever you are. It's Sunday morning over here in the US. But really, I'm here to elevate you, even if you don't have a scleral profiler, scleral topographer, scleral profilometer. You know, it's a new instrument, so we're all calling it many different things. But really, you guys are the elevators in the profession. So I did my residency down here at Bessemer Palmer. That's my residency photo there of my co-residents, and really a great year and honor. And so you guys really are the Top Gun and the Mavericks here for practitioners across the world. So I want to reflect here just for a second. I'm coming off of an incredible conference. Last week, I had the opportunity to be in Boulder with 55 of the greatest minds across the world. We had people from New Zealand coming to present from us. We had people from other parts of Asia coming to present to us on just where this industry is headed. We have some really, really amazing opportunities to help our patients with diagnostic tools. This brings me to my company in the United States. We have a thing that you can reflect on and apply your company for. My company made the Inc. 5000 fastest growing companies, and we made it as number 41 on that list. And when I was able to really reflect on what this meant for us, our patients are really driving innovation. And what I see across the industry is we're the ones that are a little hesitant to sometimes do it and be there for our patients. But the magic where it really, really happens is when we all come together and we really push forward together, because we are a healthcare team between the patients, our team, and us as practitioners. But we really are the driving force. We really are the leaders, and we have to step up into that leadership position. And we have to really figure out what fills our cup. And by doing that, then we're able to better take care of our patients and our clinics. So as you listen here the next 45 minutes or so, just I ask you, come with open eyes, open ears, and open hearts. I know this technology sometimes isn't even available where you have it, but I want you to really look at this and see how you can apply it. I did Scleral Lenses. We started fitting them in about 2010. I was not trained in school. This was something I had to learn on my own. And so it's just about continuing to be curious. That's the oath that we all took when we became practitioners. And so I hope to make this less complex for you. I like to take complex problems because I think the complexity thing, sometimes that's what people want you to think. So then you don't get into it. And I don't think that's fair. It's not that complex. We just have to understand the basics and then just keep building on those basics. I'm a big reader. There's a book here I just read called 10x is easier than 2x. And I think that this does apply here, where who wants to work smarter and not harder? We all want to see the types of patients that we want to see. And it also helps you take your practice to the next level when you're curating these relationships and when you're doing education like this. So here we go. We're going to put our hats on here and go into learning. A little bit about me. I am we met during my residency. He is a neuro-ophthalmologist in the United States, and we have two little guys there. So we have right there, I've got a 7-year-old and a 2-year-old, so that keeps me busy as a mom. So our goals is, I want you to get back to this really mindset of being patient-centric. Our industry is moving really fast in the essence that they're really trying to cut out this patient-doctor relationship. And when we do that, really everybody loses behind that. Us as physicians, our patients lose, and industry really, really loses. And so we really have to keep ourselves in these conversations. Again, coming off this one that I was just on, out of the 55 people, there were only 5 optometrists there. They are really, really coming out with some incredible things, but all of it is realizing that us as an industry, as the professionals, tend to move a little bit slower. And so we really have to speed some of that up. I want you to get back to your why. So why did you want to deal with people's vision? Why did you want to enhance their lives? And when you lead with that every morning, when you walk into your clinic, when you walk into patient care, yes, sometimes it can get mundane, but really realizing what we get to do on the other side of that slit lamp. Really introduce you to scleral topography and profilometry, and then how to simplify that scleral lens process by using technology. So again, even if you don't have access to this, this is applicable on how you can benefit your patients. This brings me here to finding your niche. I heard this quote so many times during optometry school, and I was really, really lost, not realizing that it takes you time to find your niche as you get out. So I found my niche here with Scleral Lenses. But again, my love for Scleral Lenses, really, I escalated it when I got into scleral profiling. And then also that myopia management. The US, we're eons behind the rest of the world in what you guys are doing for myopia management. So I started a whole myopia management clinic in 2016. So that's another huge passion of mine. And then really the technology piece. Not only the toys that we get to play with in the back, but really how our team is able to better take care of patients, looking them as they are a consumer in healthcare and not a healthcare in consumer. So just flipping words back and forth is really where you can accelerate. And I'm a true believer that you either pay for things with time or money or energy, or really all three. And the only difference between fear and excitement is your attitude about it. It's the same chemical in your brain that ignite fear and excitement. It's just what you want to pay attention to. Are you going to lean into the fear and let that take over? Or are you going to lean into the excitement? And this brings me to the early adopters. So what I find, especially in the United States, is a lot of my colleagues are kind of on this late majority or laggards. We have to push ourselves out of our comfort zones. We have to live in the uncomfort because change is really the only catalyst that we have, and really the only thing that keeps changing. So I'm a true believer, if you're sitting still or kind of coasting, yeah, you can coast for a little bit, but really you're coasting downhill before you can really go in and climb your next mountain right there. So where do you want to sit? This brings me to the Jetsons predictions in 1962. So here we are 50 years later, and most of this, if not all of it, has really come true. So if we look, we have flying cars. We have robots that take care of our houses. We're able to be on Zoom meetings like this from cross country. Our big screen TVs, we're able to swallow pills, and our cars are driving themselves. And then we're all just wearing technology. So I think George Jetson would really be shaken in his boots to realize it only took 50 years to do that. When it looks at patient-centric care, we have to start with the patient in mind with everything that we do. Take care of them from start to finish. Innovate with that patient experience in mind. This includes charging patients the right amount for what you do. In the United States, we deal with a lot of attorneys, and they charge for their time. We are allowed to do the same. And one thing that we do as we actually go into clinic, and we're in clinic for quite some time, you get a lot of expertise. And then we stop charging for it because we were only in there for 10 minutes or so, when initially it took us 20 minutes. And we really start to shoot ourselves in the foot when we're talking to patients and not charging them appropriately. So ask yourself, remember, it's all those eons of years and time and events like this that really allow you to bring the knowledge to your patients, and you need to charge for it. Giving the patient the control that they're asking for in a meeting. Some patients know how to ask. Most don't know how to ask you, or even worse, won't, even if they wanted to. And again, they may not even know what to ask you for. So it's just about asking better questions and being inquisitive to give that patient that best experience. If we're not truly patient, we end up again with happy patients, resentment. We tend to look greedy. In the US, we get bad reviews, and a lot of us take it personally to certain online platforms. Scleral lenses, we know we can use them for keratoconus, pellucid, status post transplants, or glaucoma surgeries, post-op corneal ectasia with RK, LASIK, PRK, high ametropia, and severe dry eye. I think it's interesting if we kind of reflect back on the last 100 years of optometry. We thought the phoropter was going to take us out of business. We thought the autorefractor was going to take us out of business. We thought RK was going to take us out of business. We thought LASIK was going to take us out of business, right? We have way more patients than ever because of these types of procedures. And then now fast forward, we have these online retailers that are wanting to do online eye exams. Again, I'm an advocate in learning about this technology. How can we utilize this technology to benefit our patients and our practices? So type in the chat here real quick, A, B, C, or D, if you are currently fitting scleral lenses. So type in A into the chat if you are, B for no, C for dabbling, or you're here to learn more. Perfect. So I love it. We've got a mixed crowd here, which is great. So let's go on here to my next one. So do you have a corneal topographer in your practice? Not a profilometer, but just a corneal topographer. So let's type in A for yes, B for no, or C, you're thinking about getting one. So again, as you look at these slides, you can look at these things with a slit lamp and bring a ton of benefit to your patients. So amazing. Thank you guys for chatting there with me. So where you can learn a little bit more about scleral topography, you can go to the GPLI. You have the Scleral Lens Educational Society, consultants, conferences, Facebook groups, and then WU University and things like this with the OOLS. So again, thank you for being here. And let's do one more poll here. What's your biggest pain point within your practice? Is it your staff? Let's type in A, figuring out what technology you should use for B, determining what to charge your patients in the optical pricing. And again, I know that this may be different. Adapting new technology or your patient adoption to new technology. I recently heard a quote that we make so many decisions a day that we get actually decision fatigue. And that comes to technology as well. So making a decision or not making the decision is a decision to stay the same. So that's another quote that I love and live by. So it's great that you guys are, we have to acknowledge this, which is great. Amazing. Thank you guys. Thank you. So let's just jump in here. Our business life cycle is, this is antiquated here, and I'll show you why. But the doctor, you have to invest in your staff. Your staff will invest in the patient care, and then the patients will invest in you. And this is a little broken because there's not enough of us to see as many patients that are out there. And so what we have to do is we have to get better use of our time. Us as doctors need to invest in technology, which then enables our staff to better take care of our patients, who then love us and take care of us. So remember, whenever we get out of balance within this cycle is when we start kind of running around our clinics with our heads cut off, right? So it's important that you go in and realize that you got to break some stuff, but then build it back up. And you really have to empower your staff. So at this conference I was at, one person, and this again, if you own a clinic, if you're an associate in a clinic, if you're a physician in a clinic like my husband, it doesn't matter. People look up to you because of that title. And yeah, you have to live up to that title. So your staff is looking to you for inspiration. And what one of them does, which I'm going to start doing, I did it a little bit, but not to really this extent. He calls it the 10-10 rule. So in the morning, for 10 minutes every morning, he goes around and he acknowledges everybody in his office. And mind you, he has 300 employees. So if this guy can do it, we can do this within our clinics. And then before he leaves, 10 minutes before he leaves, he goes back around to acknowledge everybody again. And what happens, again, we all just want to be cared for. We want to build these connections. We want to be looked at to in the eye. We want to feel important. And it's these little things as leaders that you can do within your clinic to really get your patients and your staff to the next level. We have to start with our patients in mind. What kind of experience do you want? We have this Chick-fil-A experience over here where everybody acknowledges you as soon as you walk in the door. They have a friendly staff, friendly service. They run on time. Their technology is up to date. It's convenient and easy to do business with them versus some other things in the universe. And then I travel quite a bit. I've to Europe and parts of the other world, but we really like the McDonald's. The McDonald's experiences here is a lot different than it is in other parts of the world. So even using that McDonald's experience, they're adopting technology. They're innovating for us to get our French fries faster. So that scleral lens fitting, we just have to start. You need to have patience because you have the patient. The more you do, the more experience you have, which leads to more patients. Lean on your consultants. They are fabulous people and they are a wealth of knowledge. And take images. So even if you don't have a camera, you can hold up your phone to your slit lamp and you can get really, really good images. This is how I actually now am just texting back and forth with my consultants in different areas here. Consultate when you're looking at fitting sets. So not all this may be available where you are, but the consultation, when you're wanting to hitch your horse to somebody, are they readily available? Are you willing to walk through the design process with you? Do they have a wide array of parameters available? So different types of diameters, front surface toricity, peripheral haptic toricity. So are they looking at quadrant specific designs so you can actually make that lens fit where you need to? Does it have conjunctival elevations? So can you vault over a conjuncula or a pterygium? Do they have the ability to integrate with a scleral profilometer? So they may not even have one now, but is that coming down the pipeline? What kind of materials do they have? Do they have different coatings like hydropig? Do they make different designs like a prolate or an oblate? So prolate is like most of your keratoconic patients and an oblate design is for your LASIK or RK patients. And do they have multifocal optics? And now getting into higher order aberrations. So as that is now coming on to the scene. When you walk into your clinic, I'm all about efficiency. So is your room set up properly for the little things that you have? Do you have your DMV inserters or your little plungers? Do you have the saline that you need? Do you have your fluorescein? And then do you have your fit set? So it's, again, I'm looking at that little customer experience that can really elevate everything. If I walk in and I'm already like going to the sink, washing my hands, and then putting lenses on within a few minutes, that looks way different than me trying to run around the clinic and do all these different things. This, again, is about your time and it's about efficiency. If you've been fitting scleral lenses, you've got this patient, right? Where they have been through many different lenses. And this is where I was able to invest in my clinic with a scleral topographer. We all typically have one of these in our clinic. So it's, again, looking at a very minimal area of the cornea, but it does give you some information and some data. And so when you're looking through that, this is the first device that we actually learn with our training in the United States, is how to perform keratometry. So again, all of these are at your disposal if you have them in your clinic, and just kind of move it around on different places of the eye. Could you use it in different forms? The scleral topography, and what we can do is, it's an innovative technology. It's non-invasive, where it maps the surface of the cornea, or sorry, of the scleral there. And we have advanced visual assessment and advanced customization. So all these patients where we're really understanding how the sclera really makes or breaks your fit, these are devices that we can use. Others that we have on the market, we have an eaglet, we have an S-map, we have the MedMont, which has some capability here. And then you have your Pentagam and also a I'm totally blanking on one of them. It'll come back to me. But we have many different instruments here on what you can use and what's coming out there. And this, I invested in mine in about 2016, 2017. And so all of the advancement here, they're only getting better. And again, if you don't have one of these instruments, what they're doing is they're taking the data from all of these instruments and they're making their scleral lens fits with a lot of these parameters in them, because they know now what most cases look like. Scleral topography versus cornea. If you have a corneal topographer, we're missing a lot of information. And so obviously here we're getting that, whole cornea, if you can. The white to white goes about 12 millimeters there. But then we know the scleral lens really needs to land externally. So here is what my scleral profiler is getting. We get a central gaze. The patient looks down a little bit. So we get all of the superior sclera, and then they look up and we get all the inferior sclera. Then it meshes it all together and we're able to put on a lens to the patient, and away we go. So here's some 5 things I wish I knew about scleral topography going into this. Was really how toric the sclera actually was and how this can make or break your fit. So when you're looking and you're putting a lens on the eye, you can now visually see these things without a scleral profiler. The scleral shape categories, we have 6% of our sclerals are spherical, 30% are toric, and 64% of them are asymmetric. So again, when you're just putting a lens on the eye, looking for those subtle cues, whether you're looking for a shade that comes over where the lens isn't landing right, or you're looking for some pressure or some digging into that sclera where you need to flatten it. These are all things that you can now look at different clock hours when you're fitting the lenses. Here is an image with 2 eyes of the same patient. We have a spherical sclera and a toric sclera. And you can see here in this one, this scleral topographer right here, my laser pointer. So right here and right here, you can see how toric that sclera is. So mine is actually flipped backwards. We think red is steep. This image is actually flipped backwards, where the blue is actually steep. So sometimes it gets a little confusing, but you can flip your maps. But here, if I put on a spherical scleral lens, it would be digging on the top and the bottom, and it would be very lifted on the 180 meridian right there. So our landing zone, if we mismatch it, leads to edge lift, uneven compression, symptoms like discomfort, decreased wearing time, and midday fogging, because we get all of this junk underneath the scleral lens right there. And then that is what leads to poor fluid exchange. So we're getting, again, too much fluid exchange under the lens, and that is the accumulation of tears and metabolic debris. And that's what sometimes leads to fogging. Here is an image where we have a spherical landing zone on a toric sclera. So if we jumped back a couple of slides, now you can appreciate which is actually happening right there. So this image right here, you're getting that digging right here, and then we don't have a good landing zone right here at that limbal landing zone. And so this patient would end up really, really unhappy towards the end of the day. But you can see here, I need to flatten my edges here, right? And then that would allow me to get a better landing zone right here outside of the limbus. So the data provided by a scleral map, we have this sagittal height of the eye. We know where the sclera is toric and how much is actually there. And this, again, speeds up your fitting process. When we're looking at the lens diameter, a lot of lenses, they come in that 16.0, 17.0, and some even in 18.0 diameters. But the more diameter that you're trying to fit, the more of the sclera you need to understand. So the further away from the limbus that you get, the greater the variability in the scleral lens shape. And the larger the diameter, again, the more you're going to need toric peripheral curves because it's going to be very uneven. So some of these is even fitting or starting with that 15, 16.0 diameter and seeing if you can get it. Get your feet wet with a couple of different lenses, and then you'll start to branch out into other designs. Matching the toric landing zone, so this is what the device actually does for you, is they don't want to overcomplicate the fit. And so this is on their algorithm, a very toric lens, but they know that this patient is going to be very successful because it matches right here on the blue line is what the sclera is matching. So matching that toric landing zone, we have to efficiently identify and precisely match where the sclera is toric, and that allows for alignment, comfort, decrease in all of those remakes from that patient I shared with you, and less office visits for both you and the patient. This is one of my favorite cases here. I had a LASIK surgeon call me about 4 days after this patient had undergone LASIK, and he presented with a rare complication of LASIK, which is called central toxic keratopathy. It's a rare non-inflammatory complication after LASIK. We don't really know what causes it. Could it be the iodine used by the laser? Is it a laser-induced keratocyte apoptosis? Is it from the marking pen? Is it from surgical gloves or post-debris? The signs typically begin post-operatively day 2 to 6, and it can be misrepresented as DLK. It creates a big hyperopic shift and irregular astigmatism. So you can imagine this patient was very, very unhappy. Before surgery, the patient's pre-op refraction was a plus 275 minus 5, plus 175 minus 5. And post-op refraction, you can see in the right eye, he was 2100 with a plus 4 minus 250. So again, that big hyperopic shift and a lot of astigmatism still left in that eye. His left eye was really, really good. So the surgeon was thinking, well, could we speed this up? Not only did this patient want to see because they were going in for LASIK and come out not seeing. So there's a lot to deal with there for that patient's just peace of mind. But what actually happened? Could we speed up the healing process? And you'll see here on my corneal topographer, I got a huge area flattening right here, a big area steepening. And so it's actually reversed of what happens with keratoconus. And then the left eye, we had a really good LASIK outcome here. And on the limbus, you can see just how toric this sclera is, but we want to quantify it. That's what this instrument is. I have flipped it so you can see, just as we're normally now looking, the red is steep areas. So right here, the patient has 900 microns of scleral toricity. So had I just put on a lens and fit and fit and fit and fit, this poor guy would have been on his 6th or 7th lens, because most of our lenses are making changes 30 microns at a time. And so this is something to keep in mind. Really, really look at it. Is 30 enough? Most likely not, right? I needed to go 900 microns of difference between the superior, inferior, and the 90-degree meridian versus the 180-degree meridian. And that's, again, what I want you to take from this presentation, is really understanding and looking with your slit lamp when you've got a lens on the eye, being very, really just identifying what's happening right there at that fitting zone. And that will really speed up your success. This is what that lens looked like. So you can see the big flattening areas. So right here, very, very flat, and then very, very steep. And when these patients put them on the correct way, it is a slam dunk for what they go through. So this is another image where the scleral toricity, it came out with 700 microns on the edge right here. And that, again, we had this patient on the very first lens that we fit, and he was happy, happy, happy. So here's what those edges look like. So we were not getting any digging in those steep parts of the sclera, it was just landing right nicely over the top of it. And then we didn't have any edge lift in where those areas were flatter. So if I'm fitting a spherical lens there, I'm going to see digging in the steep parts, and I'm going to see a lot of edge lift on the areas that are not touching, right? And then that's where you need to make your modifications. So just go in it. If you take anything away from this, just looking at different quadrants and seeing what you need to do. And don't think one part of your fit is going to mess up the other, because we have a lot of advancements in the technology. And this, again, is where pictures really, really come in. Put that lens on the eye, take a picture of it, and show your consultant. And they're able to make modifications for you. Where is this patient now? So 2 months post-op, we got rid of a lot of that astigmatism. So a plus 350, minus 50. He actually, about 9 months ago, underwent another LASIK procedure to get rid of the plus 350, and he's doing really, really well. CTK treatment is commonly mistaken for DLK. The onset is the key diagnosis. It's due to a non-inflammatory nature, so steroids are avoided. It typically resolves spontaneously at 18 months. This patient, we actually sped that up by about 10 to 12 months. If you want to use copious lubrication, manage the refraction, and then what we were doing with this case is we actually were putting serum tears inside the scleral lens, and the patient resolved and was in a single-use soft lens, but then underwent another LASIK procedure. So here, this brings me to another patient of having a patient with a very central cone. So this patient has 297 microns of scleral toricity. So again, just putting that lens on the eye and seeing where it's digging and where it's lifting, and you can really, really get good at this. Here's a patient with intacs. I don't know if you can see it on your end, but right here are his intacs. So you can see just on how irregular the intacs have made his cornea as well. And he has got really not a lot of scleral toricity. So we were able with him, and you can see in the image right here, there's not a lot going on that lens. We just needed to vault over his central cone, and then just that lens landed very good on the outside or on the sclera, and we didn't have to make a lot of modifications. Here, the ever dreaded decentration. So when tomorrow you go put on a scleral lens to a patient from one of your fitting sets, what happens? Sometimes this lens, it just slides right down to the bottom, right, inferiorly. And so scleral lens decentration happens from a mismatch between the scleral landing zone and the ocular surface. It's typically inferior nasal decentration, what happens, and that increases your higher order aberrations because they're not visually looking through the visual center of the lens. Leads to decreased comfort and decreased vision. So anatomically, what is happening? Our inferior sclera is about 6 degrees steeper, or 300 microns steeper than our superior lens. So what's happening is it's just the lens is tilting down. So sometimes what you'll do behind the slit lamp is you'll just take your finger and kind of roll it up, and you're like, oh man, that's right where I need the scleral lens to be. Because then that makes your vault correct over the central cornea. But now, how am I going to get the lens to stay there? So if I just squeeze or push on the bottom part to keep the lens up, maybe that's all I need to do. So really looking at if your lens decenters, that's the first thing I look at when I put on one of lenses from my fit set, is how is the lens centered? If it's just dropping inferiorly and I just need to make a toric haptic inferiorly to keep the lens up, that sometimes solves a lot of your problems. This demonstrates exactly what's happening. So that lens, again, is just sliding down. And if I just push the lens up a little bit by changing the inferior quadrant, now that lens is directly in the place where it needs to be. And that is one happy eye. So custom scleral lenses, we have those quantitative measurements from the scleral topography, which allow for those customized designs, and that overall improves centration. So again, just look at where your lens is centering. That will tell you where to go in your fit. So is it elevating superiorly? Do I need to do something there? Or is it sliding down and to the right or to the left? So nasal or towards your temporal. Elevating your fit here, again, a lot of these fit sets, they have quadrant-specific designs and toric haptic fitting sets, and it resolves decentration complications, and it also helps you quantify your fitting challenges. And a lot of these now have those user-friendly markings and labeling. So again, depending on where you are, a lot of the fit sets have gotten very, very advanced, which is great for you. You just have to start learning the language on how to talk to your consultants, and they are there to help you. To customize or not to customize, I was really nervous when I got this instrument. I was like, oh no, now all of these lenses are going to be super, super complex. Where are we really going to go from here? So what percentage of patients, and we'll have you type in the chat, did you think we're going to need a fully customized lens? 10 to 20%, 50%, or 75 to 100%? So I'll give you a second here to type in the chat. Great. So I was like most of you guys on this chat, I was thinking it was going to be a lot of people. Turns out it actually wasn't that much. So my patient population, about 25% of them needed a spherical lens, and 45% of them needed a toric peripheral curve. So these are the majority. The profile lift here, and then quad specific, and then a latitude design. So I really only needed a truly customizable lens about 20% of the time out of the 100 first patients that I saw. And again, this shows you that it's nice to have these instruments and nice to have these pieces of equipment, but you can really utilize the tools that you have. The method behind the matching here, you have the universal scleral lenses and then custom scleral lenses. So again, they want to keep it as easy as they can. Does it match their algorithm, or is it showing that they need to go customizable? And then this is, again, these images are really, really cool to show the patient on what you're doing. They want to be along for the ride and they want to understand what you're doing. So talk to them behind the slit lamp. Don't overcomplicate your FIS unless the topography data or the clinical observation warrant it. Stick to as basic as possible. And even without a scleral topographer, you can observe and reiterate your findings to your consultants, and they will help you match patients with the best lens possible. Having a very tertiary clinic here in my backyard, we do get a lot of these complex fits, and they were taking a lot of my time. And so that's, again, where I was able to invest in an instrument like this. The corneal versus corneal scleral topographer, again, where would I have gone if I didn't know all of this? But again, look at, I can get some cues from my corneal topographer on maybe what's happening in the sclera, right? So I knew that I had a very steep area right here and right here, and that actually fed into the sclera. So use the instruments that you have. Use your slit lamp. Use a fine band of light to really look at and go observe as you're sweeping the cornea, what's happening. I don't think we understand enough by just looking what we can do. Those post-peripheral fits and the toric, so you can again see here on the superior cornea versus the inferior, very, very steep, very, very flat. So this patient needed a very customizable lens. This was a patient that underwent a PK. This was actually her second PK, and you can see just a regular her cornea is. So some of these lenses, they look like they do come out of their microwave. And here is a little video, if I get it to play. There we go. And so again, just narrowing your beam of light and sweeping across, you can really, really start to get your own 3D image as you're looking at something that is in 3D. So just using your stereopsis right there, and it's amazing what your fitting consultants will be able to do if you put things into videos and put things into an understanding where they can help you. So you can see all of the edges right there. And you don't want these extreme gazes as well. So a lot of the times that lens is just going to be fitting there. If you have them look down, it'll really, really change your fit. And if you have them look up, it also really changes your fit. So keratoconus here and customizable lenses. With only corneal topography, really, where do we start? We know that this patient has a really, really large cone centrally, and away we went and manufactured a lens. So again, this patient is very toric, but not as much. So she only has 200 microns of toricity right there, but a very, very central cone. And here you can see looking at extreme gazes. So if you just, again, instead of facing the patient forward, can you come around the side and really look at how steep that cone is? So when you are putting your first lens on the eye, a lot of the fit sets will tell you to start with this fitting lens. You know you're going to be 4 or 5 lenses in, right? So where can you use the cues that you have in your toolbox and really start off with the right foot? Inferior decentration of that standard lens. Again, a lot of these are just falling off of the eye. And if you make them sit where they need to sit, you're going to have great central clearance. The quadrant specific lens designs. This was a patient. She was getting a ton of blanching and a lot of discomfort. All I needed to change were those clock hours. So we just changed about 2 to 3 clock hours right here. And now we have no blanching and that patient is super, super happy. In our part of the world in South Florida, we deal a lot with pinguiculas. So where are those pinguiculas? Again, if we're laying on that tissue and really making it hypoxic, then everything else goes wrong with that fit. So it's really nice with these instruments. It again can tell you right at the clock hour where that pinguicula is, how high the pinguicula is, and how wide it is. And that, again, will speed up your fit. The customized lens ordering and dispensing. Here you can see right here where his pinguicula is. And again, just we can make really, really cool designs when we have the ability to do so. This brings me here back to that patient failed with a 200 micron toric haptic. If you're making these changes, and we tend to make subtle changes, just go for it sometimes, right? If you're on your 3rd or 4th lens, go back to that original fit set and say, you know what, we've done this, we've done a step approach. Maybe we just need to make a quicker advancement right there. So here, that patient, you could see when we actually customized it, he goes from a lot of impingement and a lot of blanching to a very, very happy eye. So again, this was pre that toric haptic, so a lot of digging. And then here, we just started blanketing over the sclera. So again, if I share this image with my consultant, I can get here much faster without one of these devices. This brings me to number 4 is I've got 99 problems, but the sclera is not one of them in my clinic. So fixing that scleral landing zone, it relieves blanching, the edge lift discomfort, fogging, rebound redness, conjunctival prolapse, and the tear debris. So this again is what it's looking at. And we can do all of this with our slit lamp and some video interpretation. So if you have an OCT at your disposal, you can also use that. Post-tube shunts, again, I said this earlier, but a lot of these lenses do look like they came out of the microwave. And again, dealing with the glaucoma clinic here, we have a lot of those tubes that we need to vault over, and there's no room to dig in to where we have a tube shunt or where we have a trabeculectomy. Here's a patient, again, it just shows you we have to just lay right over this trabeculectomy in order to keep that trab really, really happy. So again, steep is where the lens is sitting and holding the lens up, and then it just lays over the trab. Here's a 16 millimeter scleral lens with a spherical landing zone. You can see here I'm getting a ton of blanching right over that pinguicula, and above here I've got some shadows, right? And so I'm getting a lot of tear exchange underneath this. So I need to be elevated in this area to go over the pinguicula, but I need to lay this back down a little bit more. And so by doing that, you can see here, I get rid of my shadowing effect, and I'm vaulted right over that pinguicula. So remember, time is money. Wasted time means wasted money, and it also means trouble. So before my scleral lens mapping, I did have a couple of these patients that we were just chasing our tail. And if that happens, remember, sometimes you just need to wash somebody out. Have them not wear their lens for a week and see what happens and see what rebounds, and then start over. So that's essentially what we did in this patient. We had her not wear her scleral lenses for 2 weeks. And we did each eye at a time, because sometimes these patients, we know that they can't function without their scleral lenses. And then we went back into it. This one I'm going to kind of skip here, but don't forget about other lenses in your toolbox. You have gas permeable lenses, your hybrid lenses, and then sclerals. We really kind of jumped to sclerals a lot because patients are happier with them. We can get the fit better. They're not popping out. They're more comfortable. But don't forget about these other instruments that you have. Insertion and removal. Wash your patients and discuss this with them at every visit. Discuss cleaning and solutions that you want them to use, because some of them go out very, very confused. Discuss complications and what to avoid, and upon removal, insert a couple of drops. I have them put a couple of drops of saline in the eye before they remove it, because we've all seen those YouTube videos where patients are literally plunging out their eyes. Keratoconus patients are really, really hard on their eyes. I think that they're just mad that they may have this disease, and they like to punish themselves. And so again, you have to back them off of how they're treating their eyes with eye rubbing and how they're taking out their lenses. I have them use their lower lid and push up the lens to create a bubble and create an air pocket, so those lenses come right out. This video here shows you, this was a longtime patient of mine. And I asked her, I said, go ahead and put in your lens. And I'm just, was sitting here. She like pushes her lens through her brain. This is why she was so uncomfortable towards the end of the day. So again, just little things where you think you have the perfect fit, and then this happens, and now it's not the perfect fit anymore just because of how they're inserting it. So I want you to take that away from here. What did you feel? Actually, I'm going to skip that one here. Let's go on to profitability pearls, because I know that we're in the lecture here. Be upfront with the process with your patients. The more transparent you are, the more successful that they're going to be. And at the end of the day, they just want to feel heard and cared for. Stay organized with your warranties and patient follow-ups. This is where we have in our clinic, we have these hanging bags. And in the front of it, it tells us when the lens was arrived, when the lens was ordered, when we need to return it by for our warranty. Track what is billed and what's collected. Charge for your expertise. Get your staff involved. Your excitement is their motivation. And then again, in the United States, we can sell what we prescribe. So I'm selling everything that I'm recommending to that patient, from the saline to the cleaner to the types of devices I want them to have for insertion and removal to set them up. Technology, don't ask yourself what it's going to cost me. Ask yourself what this is going to cost me if I don't do this. So whenever I'm looking at a sales pitch, I never ask them what the cost is. I say, what is the investment? So again, switching one word from cost to investment, you will expand your mind. Truly understand the ROI. What is their onboarding process? Look at their customer support. Be easy on the bugs. They're also human on the other end of this, trying to help you. Use your industry reps. They are a wealth of knowledge. And then finding your tribe. So events like this, where we get to work together. Tomorrow, as you go into your clinic, remember that 10-10 rule and see, I want you to look at what people are, how they communicate with you, right? From nonverbal cues to what they're doing. Your staff wants to know what you were doing this weekend. They want to get behind you. A 1-year plan broken into a 90-day focus session. Look at education. Submit your fellowship. Maybe on this call, you get with somebody and you say, by this date, I want to have my fellowship. Hold yourself accountable. Have your website, your brochures, your community outreach on how, again, you want to see those patients. I'm a true believer that vision is a huge gift, and us as clinicians get to do that with our patients every day and offer them that. But we also have to invest in ourselves to see the types of patients that we want to see. So with that, I thank you for your time. We have a couple of minutes for some questions. So again, thank you for letting me be here and share this with all of you.
Thank you so much, Dr. Rhue, for sharing that with us. And I think you did cover a lot of points. I thought we learn about scleral profilometry only today, but you did cover from, how to go about fitting until profitability. I guess you did cover everything within the time. So thank you so much for taking us through the entire journey, if I can put it that way.
My pleasure.
There we go. So yeah, one question I think when you mentioned, which came in earlier to me, is when you mentioned about this, the use of slit lamp only. You can fit scleral lenses with slit lamp only. This technology is more towards helping us to make it more better and things like that. So it's not that you need this technology, but a slit lamp is always good enough. Any pro tips when we are doing the slit lamp assessment? Would you kind of let us know what you do differently when it comes to just using slit lamp? Do you use tool illumination systems or have an additional light or dim light? Any those thoughts?
Yeah, I just narrow my beam. That's a great question. I just narrow my beam really, really fine. And I just start we typically ignore the sclera a lot. And so I start way far out in the periphery and I just look for those really subtle changes on where the cornea, like at the limbus where it's thinning, and you can see the shape with your beam. And you're just kind of making that 3D image of the eye. I think, especially in school, there was like a second or third year where we were learning about like the whole with like glaucoma. I was like, oh my God, this drain goes 360 degrees around the eye. I thought like from an image, it was only like this section where like it drains out. So I think we forget that we're dealing with essentially a ball, right? And you need to just fit the ball. So if you're looking at, for some reason, like orthokeratology and eccentricity, right? Eccentricity to me made zero sense. So I'll actually just show you how I identify eccentricity. Eccentricity, or a ball, has zero eccentricity. So my 2-year-old was trying to stand on a ball. And I was like, well, that's not going to work, right? But if he stands on the floor, he can stand on the floor very easily, right? And so when you're fitting a lens, is really looking at where that lens is going to land. If I have to suck it in and I have to make all of those curves, that's a really hard eye to fit. If it's more flat, it's easy to put a lens over the top. And so that's where that aha moment with eccentricity and just really understanding how to visualize in space what the eye is doing. Did that make more sense?
Yeah. I think absolutely. I think making it into simple concepts and understanding the shape of the eye is really important, right? Yeah. And one more question is regarding the use of fluorescein. So, do you tend to use fluorescein prior to the lens insertion, or do you instill fluorescein after the patient has kind of inserted and settled down a while and you have a look at the pattern?
So during my fitting, I will use fluorescein for my fitting because it's just easier to see where everything is balanced, right? So if I have too much vault, not enough vault, it's just really easy to see it. Now, when the patient comes back for follow-up, I want to see them about 4 hours after they've had the lens in. And then I will drape fluorescein. I'll have them look down and I'll just paint fluorescein on their sclera. And I'll see kind of where it's like filtering in, right? Because then I can see if it's going in too quickly in one area, that's where it shows blanching, or it shows where I have some edge lift that I need to work at. So that's where I use fluorescein.
Great. And one more question I'm just putting up on the screen is, when would you kind of choose to change the material of the lens? Is there something which you really look for in terms of signs and symptoms, and you say, oh, this is not a fit related problem, but at this point maybe I would like to change to a different material? Do you do it quite often? Is that a common practice?
No, I have found a lot of the issues that we have, whether it's midday fogging or the lens clouds up, or even it's not wetting properly, a lot of it, look back to, don't forget the eyelids. These are very diseased patients where they don't have really good meibomian glands, right? So a lot of the times it's not so much the material. All the materials are really up there as far as quality now. I don't change the material. I don't think I've really ever changed the material. It's all just comes to kind of backing out and looking at the eyelids, looking at how that eyelid is adopting. And what I'm really changing is typically what's going into the lens. So using like something like a Celluvisc or a gel drop on insertion to really cushion things and keep that lens fitting really well. And also just looking at how they're inserting these things, like that video I showed. Like if you lose all of the fluid, it's not going to be a good fit, right? And so just backing yourself down before you kind of move down that path.
Okay, great. And would you like to give any suggestions in terms of putting in professional fees? Because I guess it does require a lot of your chair time, your professional expertise and things like that, right? When patients come for diagnostic fitting. So do you ideally charge for a diagnostic fitting plus the charges for the lenses? How do you think we should go about it? Any tips?
Yeah, what I do is I kind of break this up into my professional fees and then the material fees, but I also make it like an encompassing thing. And so if you can back it back out, it's done per eye. You can do like good, better, best, or like less complex, medium complex, or super complex, and have a fee associated with that before you quote the patient. This just comes to full transparency of what the patients are going in for. And look, I'm not the doctor for everybody, and I will own that, right? But I am going to charge for my expertise. So I think that it's giving yourself the confidence to charge. You go to school for a long time. You're there on educational things like this. You can charge for your expertise. And I think it's just giving yourself the ability to get over that hump. Yes, at the end of the day, I want to help people see. I get it. But what I'm able to do is very special, and they will honor that. And I find that the more confident you are in your fees, the more confident that patient is going to be in your ability. If you're not confident in your fees, it's a reflection on you, and that patient becomes a little apprehensive. So remind that it's the vibes that you put on, like a huge person with like energy too, but it's those vibes that you give. If you come in confident and you come in saying this and don't wobble yourself out and back out, that patient will thank you. And then my thank you to patients, because they always come in and say, oh my gosh, doctor, you have this and you have that. Like, you invest in me, So I'm able to invest in you. And when you look at that circle of life of a clinician and what you're able to do, these things are able to go away.
Yeah. Yeah, I think I totally agree for charging for professional time, and because you are doing service and we want patient to be compliant as well. So if you don't charge, I feel the patient really thinks that, okay, it's going to happen and they probably are not compliant. But if you charge, you are actually making it much better for your practice because they'll be compliant and they'll not walk in with those complications and things like that. So that's really important as well. Yeah.
Exactly.
Yeah. The one last question I would just like to take up is any differences in terms of fitting scleral lenses in keratoconus or corneal dystrophies patients versus ocular surface disease? Do you do anything different when you have a patient with an ocular surface disease where you want to put in scleral lenses versus patients with corneal problems, let's say?
Another great question. What I do differently is I don't want as much vault in that patient with like a dystrophy, right? I just want that right amount, like that 250, like, and below, I think. And because you don't want all of this debris to get underneath that lens. And so these patients, when you're looking at like a corneal dystrophy, a lot of the times their sclera are pretty spherical. And so just really watching where that lens is landing and just not getting too much vault.
Correct. Yeah. And for ocular surface disease, do you tend to do it like a larger vault or things like that? Or it's more like just keeping it there and observing on visits?
Yeah, just observing on the visits. And then like scleral Johnson's and things like that, you may need a bigger lens because you want to kind of push some of that tissue away to get a better fit.
All right. Yeah. Awesome. Great. So I think with that, we have taken all questions which I see on the chat. Thank you so much, Dr. Rhue, for sharing, the entire patients and clinicians' journey while fitting scleral lenses today with us. So thank you so much for spending, again, a Sunday morning with all of us today.
My pleasure. Hope you all have a great week and hope you took something away.
Thank you so much. We do have session planned over the next weekend. Till then, take care, be safe, and I hope to see you again during the next session. Bye-bye.
Thank you.
Have a good day, Dr. Rhue. Bye. Thanks.